Hi, I'm Julie Harper from Birmingham, Alabama, and we are now going to spend a little time doing a Rosacea Therapeutic update. This is my conflict of interest statement. And I can't just do a therapeutic update without talking about just kind of our updates in rosacea in general. And so, one of the main things that's happened over the last few years is that we've really tried to get away from subtyping rosacea. So, if you're still thinking about rosacea as papulopustular versus erythematothalangectatic rosacea, try to get rid of that thinking. And the reason why is how often do you see a patient who's papular and pustular who doesn't also have erythema and telangiectasia? And it can happen, but it's not very common. So we're trying to get away from subtyping and go toward this phenotypic approach where you kind of assess the patient, and instead of trying to plug them into one subtype, you document everything that they have, and then you treat those different features accordingly. So, if you want to have some criteria for how to diagnose rosacea with this new phenotypic approach, this was published in the JAD in 2018. And these authors said that there are two diagnostic features of rosacea, that if you see one of these two, those features are enough by themselves to nail the diagnosis of rosacea. And those are persistent centrofacial erythema, so this fixed erythema, and phymatous change. So if you see one of those two things, you have got enough right there. Without that, though, you've got to have two or more of the major features, and those are things that we're used to seeing in rosacea patients. So that would include flushing, papules and pustules, telangiectasia, ocular manifestations, and you can see a list of those there. I also like that they do mention secondary features here, and many of those secondary features, not all of them, are symptoms of rosacea. And I think because it's something that's so visible, we sometimes forget that it also does have symptoms, things like burning and stinging. And then there can be signs like edema and swelling and dryness as well. We also even know that people with rosacea can complain of itching. So we're just going to say no more subtypes, get away from that. And instead of subtyping rosacea, we're going to subtype lesions and signs of rosacea and then treat everything you see. And I always make a big deal about that because I think for too long, and I always pick on metronidazole, it could be any one of the drugs that's approved for papules and pustules of rosacea. We take one product in rosacea and we try to do everything with it. And I just don't think we can do that. We're going to have to use different products, combinations of therapies. Different lesions and signs of rosacea will require multiple modes of treatment. So I would challenge all of us to really look at our treatment plans and see if there's any place where a person could benefit from a combination approach. And that's not necessarily always a combination of two pharmaceuticals. Maybe it's a combination of a pharmaceutical and a device, for example, but we need more combinations of treatment. Now, this may be a little corny to you, but I really do think in the fast-paced dermatology clinic, sometimes that rosacea patient is sitting in front of you, and before you're in and you're out, and then shoot, I forgot to talk about triggers, or I forgot to do this or that. So I really do think this can help a little bit, and that is stop, STOP. It's red, so it should make you think about rosacea here. But the S is identify the signs and symptoms of rosacea. So ask your patient. Number one, we're identifying them based on what we see, but also ask them what it is that bothers them. Is it redness? Is it bumps? And this asking part is particularly important in our skin of color patients because they also do have rosacea, and it may be rosacea, and it may be redness that we don't appreciate as much. But if we ask them, what is it that is bothering you about their skin, then they may mention redness that we don't really appreciate. The T is for triggers. Do discuss triggers, because what are triggers triggering? They are triggering pathways of inflammation. And so it's important that we know what they are. I do wish that we had treatments that fully rendered rosacea triggerless, but I don't think we're quite there yet, but we still can talk to our patients about them and have them avoid them when they can. O is agree on an outcome. And, sometimes this is very obvious. For example, they just told you what bothered them is bumps. And so our outcome is fewer bumps. But, sometimes they want to go without makeup. They want to be able to go to work out and not feel like they're going to get so red when they do that. P is develop a plan then with that outcome in mind, with everything that you've identified, as well as signs and symptoms are concerned. With all of that in play, then develop a plan. So I keep going down this pathway of combinations of treatment, and I'd like to drive that home clinically. So we'll have people where we see papules and pustules and background erythema. And right there, we know we're going to need more than one treatment because we don't have products that are FDA indicated to treat both. Maybe some of them do a little bit, but for the most part, that's two different things right there. So even from a clinical standpoint, we're going to be using combinations of treatment. But we could say the same thing from a pathophysiology standpoint as well. So right now, we think there are two main pathways at work in the development of rosacea. One at the bottom here is an inflammation through innate immunity. And then the one on the top right is neurogenic dysregulation. And so most of our products, really maybe all of our products that are indicated for papules and pustules are working somewhere on this innate immunity pathway, this bottom left. Maybe they're impacting kallikrein 5, maybe they're impacting toll-like receptor 2, maybe they're impacting Demodex. But you could block that pathway very nicely. And if you're not doing anything about this neurogenic dysregulation, which is mediated through these transient receptor potential channels. So, for example, something that is inducing heat or spicy food, maybe on the skin, causes these transient receptor potential channels to be activated. And when they are activated, they can release things like substance P or calcitonin gene-related peptide that go directly to the vessel and cause vasodilation. So the point is, you could block this innate immunity very well and still have vasodilation because we have this whole other pathway where that vessel is just really going unchecked. So combinations of treatment. I hope this drives it home again. So this is just one of our treatment algorithms. There are others out there, but all of these columns here talk about a feature of rosacea. So the first one is flushing, and then persistent erythema, and then inflammatory papules and pustules, and then telangiectasia and phyma. And what we're looking at as we look across this, if you see dots that go all the way across, then you know that that is something that works for every one of those features. And the only place where we see these go all the way across is for general skincare. And so we have very precise and specific treatments then for example, persistent erythema. We have the alpha agonist. They may help with flushing. They're not FDA approved for flushing. They're FDA approved for persistent erythema. But when you get over to inflammatory papules and pustules, there's no overlap now. So those products that were for flushing and erythema, we don't have any circles there anymore. Now we're just all about azelaic acid and ivermectin and metronidazole. When you get to telangiectasia, no overlap from those earlier ones, really, maybe a little bit with persistent erythema. But what we have to do with telangiectasia here is rely on our devices. So we're looking here at intense pulse light and vascular laser. And I don't want to be confusing with what I just said. The alpha agonist, for example, aren't going to do anything for telangiectasia because they don't have smooth muscle in their wall anymore. And so the only things that are going to work for telangiectasia are those device-based treatments. And then phyma, same thing. We don't really have anything. When we're looking at inflamed and then not inflamed, that's why it's a little bit different. But the message here is we don't have one treatment that's a do-all here. Everything is precise and specific in its action. And so I'll drive home this analogy again by just reminding us, if you went out to eat and you had a multi-course dinner with soup and salad and steak, and your waiter came to you and said, please pick one utensil for this meal. Well, you might be fine with that. And maybe you'd pick your fork, and that would be great until you went to eat your spoon. And I'm sorry, until you went to eat your soup. And then you would realize that that fork, which is so good at the steak and potatoes, is just miserable when you're trying to eat a soup with that. And we always laugh if I'm doing this live, someone will say, well, how about a spork? Well, we don't have a spork in rosacea. That's exactly my point. We don't have one product that does everything. I think in acne world, we kind of have a spork with isotretinoin, but we don't have that in the rosacea world. So when we think about the treatments we do have, we have forks, spoons, and knives. The forks are going to be, this is just play along, are the products that are indicated for papules and pustules of rosacea. And if we start at the bottom, you can see a couple of our new players. So encapsulated benzoyl peroxide, minocycline foam. And then as we go up, these are products that we're pretty used to. The spoons are going to be those products that are indicated for persistent background erythema. We have two alpha agonists. They aren't the same. They have different receptor selectivity. We have bromonidine and we have oxymetazoline. And then we have our knives. These are the device-based treatments like pulse dye laser, KTP, IPL, all of those for erythema and telangiectasia. And we have electrosurgery that we sometimes have to use for people, for example, with FIMA. But let's talk a little bit about some forks. And when I see this slide, it makes me laugh because I thought I was getting really cute with this. And I took this picture of forks in my own house. And if you look down at the bottom, you can kind of see my reflection a little bit there. And so that makes me laugh. You'll see it more, I think, when we get to the spoons. So stay tuned for that. So what are some of our newer forks? This is mostly an update, so I'm not going to go through everything we have, but minocycline, 1.5% foam is still really a newcomer. This was FDA approved in 2020 to treat rosacea. And it's the only topical tetracycline approved for rosacea. It's the only minocycline approved for rosacea right now. We do know that the tetracyclines likely do not work in rosacea by killing bacteria. They work because they're anti-inflammatory. And you can see a list of potential mechanisms there. Many of these, maybe all of these even, related to that innate immunity pathway, having effects on kallikrein 5, for example, and the cathelicidin LL37. But when we look at the studies, there were, of course, two 12-week phase 3 randomized, multi-center, double-blind, vehicle-controlled, two-arm studies in patients with moderate to severe rosacea. Pretty good size studies, 1,522 people. They had moderate to severe rosacea at baseline, and their baseline lesion count was right around 30. And in these studies for rosacea, we're always going to be looking at how many people get clear or almost clear. And we're also going to be looking at inflammatory lesion count reduction. So this is the IGA success. So these people started out as an IGA of 3 or 4, so moderate or severe. And heck, we got 50% or more of people clear or almost clear by week 12 with this monotherapy product once a day. And when you look at inflammatory lesion reduction, you can see really nice reductions here too, 64, 62% reduction, 61% reduction by week 12 in inflammatory lesions. And here's just a really nice clinical example of reductions. Now, I think you would look at this and say that there is a reduction in erythema as well, but we always have to remember there's lots of different types of erythema in rosacea. There is that persistent background erythema, there's flushing, there's telangiectasia, but there's also perilesional erythema. And I would say a lot of what she lost is perilesional erythema. If we saw only the picture on the right, that week 12 picture, and didn't see the one with bumps, we would look at that and say, well, she is still red. She is still red. So here we have minocycline, 1.5% foam. Again, some of the unique things about this is it's yellow, it may stain fabric. It does contain coconut oil, soybean oil, and light mineral oil, and you can feel that. I think actually most of my patients really like the way that feels, but because of these two things, I would prefer that we use this at bedtime. But you do not have to do that. It could be used in the daytime as well. So when these minocycline products first came out, and there's also a 4% for acne as well, my concern was, well, you cannot use a topical antibiotic like minocycline alone without co-prescribing benzoyl peroxide, because we are going to be selecting for resistant organisms. And so when this came out, I learned something, because I always thought that there was just the MIC. Once you cross this minimal inhibitory concentration, you were now going to be killing bugs that were sensitive to you, and the ones that were resistant were going to be allowed to proliferate. So it was just selection pressure and natural selection, just as simple as that. But what I was taught and learned is that it's more than that. And that's what we see on this graph. So on this graph, the drug concentration is increasing along the x-axis. And what we're looking at on the right is rate of the development or evolution of resistance. The first hashed line is the MIC. If you stay below the MIC, you're not putting any selection pressure on, so there would be a very low rate of resistance. And we know with minocycline topically, we get very, very low systemic absorption. So the amount in the circulation, the concentration in the circulation is so low that it's going to stay below that MIC. But as the concentration goes up, and in the skin, by the way, it gets very, very high. As it goes up, now we are killing the sensitive strains. Resistant strains are getting to proliferate. But as you keep going, that second hashed line is now the MPC, which is the mutant prevention concentration. And once you cross it, your concentrations are so high that nothing can outlive that. And so now you're killing even the most resistant strains. And because the minocycline levels in the skin are so high, we believe that's where that product is living when it comes topically. So can a topical exist and not put selection pressure on and not select for resistant organisms? I'm going to say maybe. And that was something that I definitely learned when that product first came out. We have another very newcomer in this space. We have benzoyl peroxide, and the mechanism of action in rosacea of this is really unknown. Probably it's working because it does have an impact on Demodex, and Demodex is a trigger that triggers inflammation. And so this would be one way where benzoyl peroxide could be anti-inflammatory. But I would also say it may be that because of how well this benzoyl peroxide worked in studies, it may make us rethink the pathogenesis of rosacea a little bit. And so we can stay tuned on that. But this is not just any old benzoyl peroxide. Please do not go out and just start writing any old benzoyl peroxide for your rosacea patients. This is 5%. And more importantly, it's microencapsulated benzoyl peroxide. So it is wrapped up in a silica shell and multiple layers of this silica. The best description I've heard is it's like cabbage leaves. And so this is not a solid shell. This is fenestrated, discontinuous, whatever you want to call it, that allows the benzoyl peroxide to gradually, slowly release from the product. And this enhances effect, but also enhances tolerability. So this is now FDA approved for the inflammatory lesions of rosacea. There were, of course, 2 phase 3 clinical trials, 733 patients. The baseline inflammatory lesion count was 26. And then again, everybody in the study had moderate to severe rosacea. And again, as far as getting people to clear or almost clear, 44% in study 1, 50% in study 2. Nice big delta compared to its vehicle. And when you look at lesion count reduction, it's about 70% lesion count reduction at week 12. And one thing that we like even better than this is those numbers at week 2. At week 2, over 40% reduction of inflammatory lesions. So 70% at week 12, but over 40% at week 2. And here's just a nice clinical example. An IGA of 3 at baseline, and then at week 12, almost clear. He's gone from 20 down to 7 lesions, and that's just in 12 weeks. So again, this is that encapsulation process that I was talking about with these, repetitive cycles that build up the silica shell that allow the product to be more slowly released onto the skin. And that is what was seen. These are people with rosacea. We don't typically think of them as having, really robust skin that can handle just anything. But this 5% microencapsulated benzoyl peroxide was actually tolerated very well. If you look at the related adverse events, which is the bottom half of this, you'll see for application site pain, for example, only 2%, application site erythema, 2%, pruritus, 1%, edema, 1%. So very well tolerated. Okay, so this is certainly not new. Modified release doxycycline, 40 milligrams. By the way, we're still talking about forks, only forks, okay? This is the only oral drug FDA approved to treat rosacea right now. And it was FDA approved in 2006. This is reducing inflammatory lesions of rosacea. It's not indicated for persistent background erythema. It is also not just 40 milligrams of doxycycline, it's modified release. So it's 30 milligrams immediate release and then 10 milligrams of delayed release. And it was formulated like this to maintain a sub-antimicrobial dose. So this does not select for resistant organisms. Low dose is not the same thing as sub-antimicrobial dose. And this is something that with the microbiome, this is an ongoing area of discussion where we're all going to continue to learn more about this. But we do believe that this is a low enough concentration or a low enough milligram. And with the 30 milligram immediate and 10 milligrams of delayed release, we're able to stay below an antimicrobial threshold for the most part. And this has always been a slide that I think really drives the point home. So the orange is the modified release doxycycline. The gray is doxycycline 50 milligrams. So I would call both of those low dose. And yet we see that the doxycycline 50 milligram once a day does come up with that peak dose pretty quickly, by what is that, hour 2 or 3. That hashed line is kind of an average MIC antimicrobial threshold. And once you come up over that, Again, this is nothing nefarious. It's just that once you cross over that, you are acting as an antibiotic and you are going to kill the bacteria that are sensitive to you. And then the ones that aren't get to become resistant. And we don't see the sub-antimicrobial dose or the modified release doxycycline ever coming up over that threshold over this whole 24-hour period. I mentioned that because I did want to talk about sarecycline. Now, sarecycline is not FDA approved to treat rosacea, but it should work. And in fact, in a pilot study, it did work. So one thing that's unique about sarecycline is that it's narrow spectrum. So it works for gram-positive organisms, but has minimal activity against gram-negatives, for example, in the gut. So this is just hopefully a safer way for us to treat inflammatory conditions like rosacea or acne, where we're really trying to target gram-positive and not gram-negative. This is FDA approved for acne in 2018. Well tolerated, very, very low rates, really almost no vertigo, dizziness, or sunburn, low rates of GI disturbances. And this is weight-based dosing with or without food. And again, this is what I'm talking about with that narrow spectrum. So Doxy and Minnow, by the way, would be over here on the blue side. Broad spectrum, they're going to hit a lot of those things. We know sarecycline, not so much. It's going to come in and hit gram positives and leave a lot of those other players, just leave them alone. But there has been a pilot study done in rosacea. We've already said we think the tetracyclines work, not because they're killing bugs, but because they're anti-inflammatory. We would think that would be true about sarecycline as well, too. But this was a randomized investigator-blinded 12-week study of people with moderate to severe papulopustular rosacea. Again, it was weight-based dosing, 72 people in the sarecycline group, and then 25 people were treated with an oral multivitamin. So this was only investigator blinded. You kind of knew as a patient if you were taking a vitamin or if you were taking sarecycline. But they were able to get 75% of people clear or almost clear at week 12, compared to 16% with the multivitamin. So maybe we're not going to be treating rosacea with multivitamins. And then when you look at lesion count reduction, 80% reduction at week 12 with sarecycline. Now, this is, investigator blinded. The multivitamin didn't do half bad here, but we still had a good, strong p-value at every time point comparing these two arms. And again, your N is kind of low, but it still was effective here. Okay, here are the spoons. Oh, you can see my hands there in the bottom with my phone, trying to take a picture of these spoons. So persistent facial erythema. Now we're not talking about bumps anymore. We are talking about products FDA approved for persistent background erythema. One of those is oxymetazoline. And I think one of the most interesting things that we've been talking about lately is, do we really change the disease course? Do we change the vessel in rosacea if instead of using an alpha agonist just every now and then, just when we don't want to be red, instead, if we use it every day, do we maybe stand to change the disease a little bit more? And so this is the oxymetazoline cream 52-week study. So in a 52-week safety study, there's no comparator. We're not comparing to vehicle. Everybody is on the drug. So this was 440 people. They were moderate to severe erythema at baseline, and they applied oxymetazoline daily in the morning for 52 weeks. And what's really interesting, so what you see on here, anytime you see the blue, that's pre-dose on the day that you're looking at. The orange is at hour 3 and the gray is at hour 6. So on day 1, nobody at pre-dose was already meeting the 2-grade composite improvement. Remember, in these studies, both the investigator and the subject got to rate, and they had to both agree that there was a 2-grade improvement. Of course, they didn't get to commiserate about that, but if they both agreed, then they were a success. So nobody did that before they put the drug on day 1, 11% by hour 3 on day 1, and about 18% by hour 6 on day 1. But when you get to week 4, maybe there is an additive effect. And in fact, now we've got a sneaky 1% of people who are already meeting the endpoint and they haven't even applied the medicine. And then you get to week 26, and now 6.5% of people are meeting the endpoint before they apply the product. And at week 52, 1 out of 10, a little bit more than that, are already meeting a composite 2-grade improvement, and they haven't even applied the drug yet. And then when you look at hour 3, compare hour 3 on week 52 to day 1, we've got just this additive improvement over time by using this consistently and using it every day. And I can show you this photographically too in this guy. So we see him day 1, pre-dose, hour 3 and hour 6, and then we see him at week 52, pre-dose, and then hour 3 and hour 6. And if we just kind of hone in on pre-dose and then week 52, this is what we see. And I think we can see that, he hasn't even put that on yet. And it's a dramatic improvement when we compare it to his pre-dose on day 1. And so that's kind of an update on the therapeutics of rosacea and really just the diagnosis of rosacea. I think if I wanted to get anything across to you, it would be, don't try to do too much with one product. Remember that we have different tools and devices that work for different components of rosacea. And we are all interested in not just getting part of rosacea better. We want to get it as close to clear as we can. And so don't try to do too much with one tool. Really pull out multiple implements for your patients and treat them with more than one tool. Thanks for listening.